So colleagues, welcome to this Usher COVID-19 webinar from the University of Edinburgh. Good afternoon to all of you, or good evening, depending where you're joining us from. And my name is Linda Ball, Professor of Public Health in the Usher Institute. I know many of you have joined these webinars before. This is in fact our 20th webinar in the series. But bear with me just while I briefly run through how we set up these webinars so you know how they run, and then I will introduce our speaker. So you're able to enter questions into the question and answer box, which you'll see at the bottom of your screen, not the chat function, but the Q&A function. And as you're listening to our speaker, please do put in any questions you have about the data that's being presented or the information generally, or indeed anything else you would like to ask about Iceland's experience during the pandemic. And then I will choose those questions at the end. If you see other people asking questions that you're particularly interested to hear answered, do put up the thumbs up sign next to that question, and then I can see the answer to that. So just a reminder, the webinar is being recorded and it's also being live streamed, and after the webinar, PDFs will be available as a, slides will be available as a PDF. So I hope that you'll find this interesting. So I'm going to introduce our speaker now, and at the end we have one further webinar set up so far that I will also say a few words to. So I'm really delighted that Dr. Kari Stefansson has been able to join us today. He's the founder and CEO of the Reykjavik-based deCODE Genetics. Many of you will have heard of deCODE and their very impressive work. So he's pioneered the use of population scale genetics to understand variation in the sequence of the human genome. He's published more than 600 scientific papers, and he's really pioneered a population approach in Iceland, which has served as a model, as many of you will know, for national genome projects around the world. Before founding deCODE, he was a professor of neurology, neuropathology, and neuroscience at Harvard. He's previously held a number of faculty positions at the University of Chicago, for example. So there's more of Dr. Stefansson's biography on our website. Please do have a look at that, but I don't want to take up more of his speaking time. So I will hand over now to Dr. Stefansson, and he's going to share his slides and give the presentation, and then we'll have a discussion. So over to you, Kari. Thank you.
Thank you. All right. Good afternoon from Iceland, and I wish that the story I'm going to tell you today would be simply a success story, but unfortunately it isn't. But we started to screen for SARS-CoV-2 in Iceland at the end of January, and we identified the first case on February 28th. And we started to screen asymptomatic people in Iceland on March the 13th. deCODE Genetics joined forces with the government, and because simply the government wasn't equipped well enough to handle this alone, at deCODE we put almost all the effort of the company for about 3 to 4 months on assisting with the screening. But we did not only screen for the virus widely in the population, we also sequenced the virus from every single case diagnosed in Iceland, and we continue to do so. So basically, by May 26, we had screened about 17% of the population, and at that time, the first wave of the epidemic was simply over. We gathered very large amount of data very quickly when we started this work, and we actually had submitted a manuscript for publication 12 days after we started the screening. And actually, because we sequenced the virus from every single person diagnosed, we got a very early look at where the virus was coming into the country. To begin with, the authorities in Iceland focused on people coming from skiing holidays in Austria and Italy, and actually people coming from those regions that were early classified as high risk, were put in quarantine. But as the authorities were focusing on people coming from Austria and Italy, and we started to screen widely in the population, it was clear that the virus was sneaking into Iceland from many other countries outside of Italy and Austria. And Great Britain was a very important source of virus coming into Iceland. So probably the virus had a wide distribution in Great Britain before the authorities in Great Britain realized it. And once the virus came into Iceland, it turned out to be extraordinarily important to have the sequence information when we started to trace the spread to the virus in our society. For example, if Peter infected John, you expected them to have the same haplotype. And if John had one additional mutation on the top of the haplotype, we knew that it was Peter who infected John, but not John who infected Peter. Early on, the authorities put in place the following measures. We put a ban on assembly of more than 20 people. We closed movie theaters to orchestra halls. We implemented 2-meter social distancing. We closed the schools except for the elementary school and the childcare centers. And actually, once these measures had been put in place, we started very early on to see a sign of decreasing transmission of the virus. But it is interesting if you look at the way in which the virus was spreading in our society, that in the beginning it was coming from outside, then that was taken over by a period when most of the transmission occurred in people's interactions outside of the home. But once these measures were put in place, a few days later, it was clear that most of the transmission occurred within families. If you look at this, at the picture on the upper left-hand side, what you're seeing there is basically sort of the display of the cases according to haplotypes. And what you see towards the bottom of the circle is a bunch of cases with the A2A3 haplotype, which is a derivative of the Italian haplotype coming from Spain. And actually that group of people happened to be a choir. And basically every member of the choir was infected in one choir practice. And it was due to a woman who was coming from Spain after having been on a vacation in Spain. And on the right-hand side, the upper right-hand side, is a picture showing how we were using the haplotypes to map the spread of the virus and trace it from one individual to another. For example, the T25 is an individual who are heteroplasmic for a particular mutation. And as you can see, distal to that, there is just one of these two haplotypes that was found in him survived. One of the things that happened gradually as the time passed is that the haplotype composition, what we found when we were sequencing the virus, changed. In the beginning, it was dominated by the haplotype coming from Italy and in Austria, the A2A1 and the A2A2, but gradually it was taken over by other haplotypes, such as the A2A1 coming from Great Britain. One of the things that we did early on was begin to look at the transmission of the virus or to children and from children to others. And the reason we started to focus on that very early, it was rooted in the decision of the authorities to keep their childcare centers and the elementary schools open. And the decision to keep them open was that it was considered to be very important for the healthcare system, for the national hospital, because a lot of the critical staff at the hospital have children at that age. So it was considered to be very important in the attempt to keep the hospital functional during the epidemic. And actually what we did is that we we took people who had been put in quarantine for all kinds of reasons, and we looked at the ratio, looked at the percentage of children versus adult who got infected being in quarantine. And it's absolutely clear that children were less likely to get infected in the quarantines than the adults, substantially less. And actually it somewhat depends on age, because if you take individuals over 50 years of age, almost half of them got infected, whereas children between 0 and 15 years of age had about 15% probability of getting infected. And keep in mind that at the time when we are looking at this, the children were much more exposed to the environment, to the outside environment, than the adults, because we kept the elementary school and the childcare centers open. But it's more than that. They are less likely to get infected. It's also clear that they are less likely to infect others. So when we take children at various ages from 0 and up to 15 years of age, they are substantially less likely to infect each other or to infect adults than adults are to infect each other and children. We have actually made sure that this is not accounted for by viral load, because the viral load in children equals that of our viral load in adults. These data are highly significant, but it is extremely important to emphasize that even though children are less likely to get infected, they get infected. And even though children are less likely to transmit the virus than the adults, they do transmit the virus. So the results of this is no justification for insisting that children do not play a role in this epidemic. At the end of April, beginning of May, basically this phase, or the first wave of this epidemic was over in Iceland. We had pretty much gone down to no case diagnosed each day, and we felt relatively comfortable about it. And actually, the decision was made to sort of open up the country on the 15th of June, and I will come back to that in a minute. But one thing we did, once that phase was over, to begin to look at it, to look at the viral load, and we basically used the cycle threshold as a measure of the viral load, and we also used accumulation of mutations as a measure of viral load, because the accumulation of mutation is dependent on the viral load. And remember, the virus basically only accumulates more mutations when it is transmitted between people. And we basically showed that in the growth phase of the epidemic, the viral load to those who were diagnosed was very high, and there was a very rapid accumulation of mutations. And in the containment phase, the viral load went down, and the accumulation of mutations were substantially slowed down. I will come back to that a little bit later in this presentation. The next thing we did was that we did a fairly large study of the humoral immune response to SARS-CoV-2 in Iceland. We basically screened about a little bit over 30,000 people. In the beginning, we took serum that had been collected in 2017 to help us to assess the specificity of the tests that we used. We also looked at serum that were collected early in 2020 up until from 18th of February up until the 9th of March. We looked at people who came through the healthcare system for other reasons than COVID-19. We looked at random sample from the population. We looked at the people in quarantine, and of course we screened all of the people who had been diagnosed with the disease. So this was a fairly comprehensive study of the humoral immune response. And we tested out 6 assays. And the assays that turned out to be best in our hands was the Roche assay, which is a pan-immunoglobulin assay against the nucleocapsid protein, and the Vantai assay, which is a pan-immunoglobulin assay against the receptor binding domain of the spike protein. And basically the false positive rate in the pan-immunoglobulin assays was about 0.1%, and the false positives were non-overlapping. So we decided that we would not call someone positive unless it turned out to be positive both in the Roche and the Vantai assay. And actually, there are several factors that have significant impact on the antibody titer, and that includes age and sex and body mass index, smoking or non-smoking, use of inflammatory medication. It depends on how seriously ill the patients were, etc. So basically, if you look at it, the antibody level goes up with body mass index. So if you take, the higher your body mass index, if you get sick, the higher your antibody titer. I'm not sure how meaningful it is, because if you take any protein in plasma or people, all proteins are correlated with body mass index. So it may simply be the same thing that dictates the increase in all proteins with BMI. But the level definitely goes up with age significantly. And the antibody levels were lower in females with 2 of the assays measuring antibodies against the spike protein. And the antibody levels are lower in smokers and the use of anti-inflammatory medication, and antibody levels are generally higher in those who become more sick or become sicker. And it's interesting if you look at just those who were diagnosed with qPCR, 91% of them turned out to be antibody positive, but there are 9% who are not antibody positive. And if you release a little, or if you decrease a little bit the threshold, and you decide that you're going to go with just one of these 2 assays, either the Roche or the Vantai, then additional 4% to 4.5% would classify as having antibodies. So there is about 4 to 4.5% of those infected who do not have a trace of antibody against the virus in the assays that we use. If you look at, it's interesting when you look at the antibody level of the serum positivity in those who were in quarantine. Basically, if you take the quarantined individuals, because the way in which this was done is that not only did we put on restrictions on people's behavior, we also had an extraordinarily agile, active, and effective contact tracing team. They went all the way to using apps on cellular phones to identify people. And I'm absolutely convinced that a key to our success in the first wave of the epidemic was the contact tracing. And the people and the contacts were put in isolation, and most of them were not tested unless they developed signs or symptoms. But if you take the individuals in quarantine, if they were in quarantine and there was not a household exposure, about 10% of them turned eventually to be positive on qPCR. Those with household exposure, about 36% of them turned out to be positive on PCR. Without symptoms, only 10%. With reported symptoms, they went up all the way to 66%. But when we looked at those who turned out to be negative on PCR or had not been tested and were in quarantine, if there was no household exposure, 1.4% of those turned out to be antibody positive, 7% of those with household exposure, 7.1% of those with reported symptoms, and 2.3% of those who were in quarantine without any signs or symptoms. If you just look at the fraction of those positive for the pan-IG SARS-CoV-2 assays, the one tie or the rows, it's interesting that the antibody, of course, rose faster and went a little bit higher in those who have been hospitalized. But it turns out that about 25 days from the qPCR diagnosis, over 90% or 91% of them who recovered were positive in both of these assays. And after that, the antibody level remained mostly stable. If you look at these various assays, the top on the left-hand side is the Roche assay against the nucleocapsid protein, followed by the one tie against the receptor binding domain of the S1, and they rise for 25 days and they remain stable after for 4 months. There is a tiny little bit dip in the antibody titer as measured just with IgG against the nucleocapsid protein, and then as expected, there is a rapid rise and decline of IgM, and basically the same applies to, or not quite as rapidly, but the IgA rises relatively swiftly, and it tails off for about 75 to 100 days. And if we take ask the question, what are these data? If you combine the PCR data, qPCR data, with the antibody test, what does it tell us about the true distribution, the true spread of the virus in the Icelandic population? And what does that then tell us about the death rate from the virus? Basically, if you add up all of these things, if you add up the qPCR and the antibody, it turns out that about 0.9% of Icelanders were exposed to the virus. And if you just look at the PCR, about 0.6% of the population was exposed to the virus. And if you just look at the PCR data, it looks like 0.6. There was a 0.6% fatality rate in Iceland. But if you add on to that the antibodies, it turns out that the fatality rate is about 0.3%. And keep in mind that only half of the cases were diagnosed with qPCR. So it is absolutely clear that it is a very substantial percentage of the cases in Iceland who were asymptomatic. About 40% of those who were diagnosed with PCR were asymptomatic at the time when they were diagnosed. My guess is that a fairly large percentage of those subsequently developed signs or symptoms, but basically about half of the cases, a little bit less than half of the cases, were at least sufficiently asymptomatic not to be diagnosed with PCR. So if you look at the summary of what came out of the antibody studies, we looked at serum from about 30,000 individuals and measured or looked for antibodies against either nucleocapsids or spike protein using 6 assays, but relying mostly on 2 assays, one against the nucleocapsid protein, the other against the receptor binding domain of the spike protein. And to call someone positive, we demanded that they were positive on both of these assays. If you look at individuals who were quarantined and did not test positive on qPCR or had not been tested, 2.3% of them turned out to have raised antibodies against the virus. If we took random selection of individuals and all comers to the healthcare system who were neither quarantined nor PCR positive, 0.3% of them turned out to be positive. Of cases recovered from the virus, 90% had antibodies detected with both assays, or 91%, with very consistent results when repeated up to 4 months after diagnosis. And the antibody levels, as measured with both PAN and IT assays, increases for the first 2 months after qPCR diagnosis, and then plateau and remain on this plateau for an additional 2 months. So for 4 months after diagnosis, the antibody level remains up, which to me, because this is a fairly comprehensive study in Iceland, I think that it is probably closer to the truth than previous reports that were much smaller, reporting a early and steep decline in antibody titers. Antibody levels are higher in sicker patients and in older individuals and males, mirroring the relationship between age, sex, and the severity of the COVID disease. And of course, one of the questions that this always raises is whether the antibody plays a role in the pathogenesis of the disease in those who get really sick from the disease. 0.9% of the population of Iceland was infected with SARS-CoV-2, but only about half of them diagnosed with qPCR, in spite of extensive qPCR testing in Iceland. And the infection fatality rate is about 1 in 300. So what happened in Iceland at this time is that the cases had come down, everyone had recovered, and there were basically no new cases that are being found, and there was a mounting unrest in the population. The tourism industry became very impatient, and the question was raised: what should we do? Should we simply wait, keep the country closed until a vaccine has arrived, or should we try to use some method to ensure that even if you open up the country and let in the tourists, because the tourism has become basically the biggest industry in Iceland? And what was decided, or the government decided in its infinite wisdom, and I confess responsibility for having suggested it to the government, was to open up the country in such a way that everyone coming into the country would be screened with qPCR. One screening, and people would get into the country. And basically what we learned fairly soon after we started is that even though the number of people who tested positive at the borders was relatively small, for every 10 individuals who were diagnosed at the borders, 2 to 3 made it into the country without being in court. And it's interesting, the first serious consequence of that was when a young woman came from the United States. She was tested at the borders, was negative, but the day she came to the country, she got a phone call from a roommate of hers in the States telling her that she had tested positive. So she went again to be tested. She had, before she was tested, before she got the phone call, she had gone to some gathering of people. And it turned out that she had infected 5 individuals or so before she went into quarantine. There was another woman coming from Albania, and a couple of days after she came into the country, she got a phone call from the airliner that she had used, and she was told that there was someone infected on the plane. So she went back to being tested, and she turned out to be positive. So, and in the meantime, she had infected 5 individuals. So these 2 outbreaks were easily controlled. But it sort of emphasizes the fact that very early on in the infection, before the virus has had an opportunity to proliferate enough, the amount can be sufficiently little that you cannot pick it up. And actually, the 3rd outbreak was substantially greater and came up in several places in Iceland. And the reason we know that this was only 1 individual had made it into the country is that all of them had the same haplotype. And it just emphasizes the importance of being diligent in sequencing the virus, because that is the only way in which you can determine really how many sources you have of an infection like this. And this ended up being probably about 100 to 120 individuals who were infected. So on August 19th, it was decided to screen at the border, have people then go into 5-day quarantine and screen them again. And when this decision was made, we had fairly good sort of feeling for how long time it would require for someone who had just been infected to have enough of the virus to be picked up. One possible one event that helped us with that was when a couple of individuals who came to Iceland and were put in quarantine, were infected, and they basically broke the quarantine and drove into the countryside, were approached by the police, were arrested, and there were 5 policemen who arrested these 2 individuals. And 2 days after the arrest of these unfortunate tourists, 2 other police officers were positive, and 2 days after that, the remaining 3 had become infected. So it was between 2 and 4 days that it took for the officers of the law to pay the consequences of having interrupted the pleasure trip of 2 Romanians. But anyway, in spite of that, in spite of the double screening, we have had a very serious group infection in 2 pubs downtown Reykjavik on the 18th of September. And they turned out to have a haplotype that was first identified on the 15th of August, or 4 days before we instituted the double screening, separated by a quarantine. And this haplotype was first seen in 2 French tourists who came to Iceland, were put in isolation, left the place where they were in isolation, were caught pretty soon after that, but it isn't absolutely certain that they started this outbreak. It could equally well have been someone on the airplane with them who got infected, who went into the community. And it turns out that the risk of tourists is much less than the risk of the natives if they become infected, because of the much bigger social network. But we were unfortunate when this outbreak happened on the 18th of September. The decision was made not to tighten the rules in response to it. So that wasn't done until just a couple of days ago, or 3 days ago. And I'm just showing you this one example of how important having this sequence is that there was an outbreak of about 30, there were about 30 individuals in the National Hospital who got infected. And we could basically, by sequencing the viral genome from all of them, we can determine that there were basically 2 infected individuals who brought the infection into the hospital. It wasn't that many of the employees had come into the hospital and spread the infection. I want to remind you what I told you before, that early in the growth phase of an epidemic like this, the viral load in those diagnosed is high, and there's a rapid accumulation of mutations. And then in the containment phase, the viral load goes down, and the accumulation of mutations also goes down. And actually, if you look at the haplotypes that have been diagnosed in Iceland by day, sort of since this outbreak on the 19th of September, we see a little bit of the haplotype that I showed you, the old haplotype from the previous outbreak, the green haplotype. But it is clear that the blue haplotype, the one coming from France, that we labeled, A2, A2B1, is on the rise, has been dominant in Iceland since then. And what is more, when we look at the cycle threshold, the CT number, and what the red line is basically the CT number of the cycle threshold for those who are diagnosed at the borders. And it is clear that the cycle threshold is fairly low in Iceland today. It is lower actually than it was in the growth phase of the epidemic this spring. So people on average seem to be diagnosed with a higher viral load. And what is more, the accumulation of mutations is fairly fast. So these 2 parameters that we have used to assess the phase of the epidemic indicates that this current phase in Iceland is in rapid growth. And actually, the accumulation of mutations has been fairly fast. And actually, the number of mutations is in many ways a measure of the number of cases in the original case with a specific haplotype. And the accumulation is 1 new mutation every 4th case. Or another way of looking at it is basically 1 mutation every 14 days. So if you look at what is happening in Iceland now, and we look at the incidence which is basically number of new cases per 100 inhabitants in 2 weeks, that it has been growing rapidly in Iceland. It is over 180 in Iceland, so we are clearly in a very difficult spot. And actually, if you look at the same kind of a graph that I showed you being so spectacular in May in Iceland, where the number of recovered cases equaled that of, or basically had taken care of everyone who had active cases at any point in time. And basically, this is what we have today. We have, in a country of 360,000 people, we have 4,000 in quarantine. We have almost 800 active cases in isolation. So the lesson from this is, number one, I think that when you're living in a country that is an island in the North Atlantic, all right, you can contain an infection like this if you behave reasonably. We made a mistake on the 18th of September when we should have reacted swiftly, but we didn't. We were governed by wishful thinking, hoping that this would just take care of itself. But now we have, for 2 or 3 days, we have had in place the same kinds of restrictions that we had this spring. And I am hoping that we will be seeing within the next few days the decline in the viral load, the increase in the CT numbers, and the decrease in the accumulation of mutations in advance of the decrease in the number of cases being diagnosed each day. And that's about it. Thank you for your attention.
Thank you very much, Dr. Stefansson. That was really interesting, and we're very grateful for all the detail you provided, and also just the update in terms of the current situation, which of course, as you say, has changed rapidly. So we've had a number of questions. Thank you to the colleagues who put the questions in the box. If there are any others that occur to anyone, do please add them in. So I'll just start from a question that is from Dr. Richard Simpson, who was previously a member of our parliament and also a doctor. And he asks, is there any variation in infectivity or spread related to different haplotypes?
There is no evidence in that. People were publishing on the possibility that a specific mutation, particularly one specific mutation, was spreading more rapidly than others, and there is a circumstantial evidence in support of that, but no one has been able to nail it conclusively. So most of the variability you see has to do with behavioral people. So there are two problems that we are dealing with. Number one is the virus, and number two is our own species.
Yes, we know this from the UK as well. It's the behavioural elements are very important. And Professor Lawrence Gruer has asked, has there been any retrospective study of relationships between asymptomatic cases and other cases in relation to the role of transmission from asymptomatic cases?
One of the things I can tell you is that the cases that have only been diagnosed with serology, the ones that were not diagnosed with qPCR, but we identify them subsequently, we have not been able to document a lot of spread from them. We've been trying to do it, but we haven't been able to document a lot of spread from that. But there is a sort of we are currently calling in everyone who has been diagnosed with COVID-19 in Iceland in the first wave, and we're going to do it also with the second wave, and we are phenotyping them for all organ systems. We are, testing cognitive function, smelling, hearing, vision, you name it. They come in for about 5-hour study. And in that visit, we are going to push harder trying to get information on what it really means to have been quote unquote asymptomatic. Was it just people who were mildly symptomatic, or were they truly symptomatic? Keep in mind that the first wave in Iceland was during our cold season, so there's a substantial overlap between the signs and symptoms of COVID-19 and just a common cold. So we are trying to clean that up with a study which is aimed at figuring out what are the long-term health consequences of having been diagnosed with COVID-19.
Yes, I think that's a great attention, isn't it, internationally, that particular topic, given, we have not had the virus circulating in countries for many months, so we need to look at the longer term and understand that better. Ros Pollock has asked, this is a question or a topic we've covered in the webinars before, which is this strange relationship with smoking and tobacco use. So Ross has asked quite rightly, and as you'll know, we see that from many cohorts around the world. It looks like smokers had lower levels of antibodies. So what are your thoughts on this? I know that the speculation, Dr. Stefansson, is about, sorry, go on.
Smoking is a complicated phenomenon. Smoking increases the death rate from all-cause mortality. Smoking has an impact on so many things that I'm not surprised to see this, but I have no explanation for you, except my recommendation to you, like everyone else, is don't smoke.
Yeah, we're very interested in that. There's all kinds of theories about the ACE2 receptors and the role of nicotine, and there's all kinds of things. they seem to be fewer cases, but then they have more disease severity, etc. So it's a really interesting debate.
And it is a complicated, it's a complicated stuff, because smoking increases the risk of all kinds of diseases. So is smoking having a direct impact on this, or is that impact mediated through other diseases that the smoking affects? It's a complicated system. My recommendation to everyone is just study something else. It's too complicated.
Well, yeah, I can understand that. Next question, are you following up beyond 4 months the antibody levels, as this could be of great value in stratifying vaccine and timing of vaccines?
We are definitely, we are calling in, as I told you, everyone diagnosed, and we are going to collect serum from everyone. We are going to continue to measure the antibody level. I agree. It is critical, you know.
Are you doing any of the plasma studies, the convalescent plasma studies, or is that not happening in Iceland?
As a therapeutic? No, we are not.
I know other countries are looking at that. Thank you. Is there any information, this is from Professor Porteous, is there any information on infectivity or spread and severity of response related to human genotype?
Everyone and his grandmother is looking at this, but and there are some studies of variants that have subtle effects. There are about several variants that have been proven to be genome-wide significant. But in Iceland, it is difficult to study this because we, thank God, we don't have what we need to be able to study it. What you need are more cases, all right? We are so few of us that you're not going to find anything significant in just in Iceland. But we are a part of international consortia. We have contributed our material to several international consortia. And my prediction is that, yes, we are going to find a lot of common variants with relatively small effect. But that is not going to be a major determinant of how people fare in this epidemic. It doesn't look that way. Otherwise, we would have seen the signals already.
Yeah, so it's the risk factors, isn't it, that really determine the demographics, the underlying conditions, obesity. Yeah. Okay. Are the factors related to antibody levels also seen with other infections in the same way? I'm not sure what that question means, actually.
I don't have, you see, I don't have any data showing that. I can assure you that a lot of what we are seeing in COVID-19 is going to be shared by other viral infections. This one has been studied so thoroughly. I mean, if you take, for example, the sequencing that we have done of this virus, we have sequenced it from every single case diagnosed in Iceland. That has never happened, not in any place in the world, in any epidemic of viral infection. So we are very rapidly learning an awful lot about this virus and the disease it causes. But my guess is that there's going to be significant overlap with many other viral diseases.
So another question here is about the school children. So the data that you have collected and analyzed on children, I think, has been very valuable internationally. I know we're all aware of that, but I guess this is a question in relation to the current wave of infections. So are you seeing significant spread amongst children and perhaps university students in this current outbreak?
This current outbreak, you see, the mean age in this current outbreak is substantially lower than in the first outbreak. It started off in one of the establishments that is more frequently attended by young people than older people, one of these bars or pubs or whatever you want to call them. And it seems to have spread much more among young people than elderly, but it is gradually filtering up to the parents and the grandparents. And we have a significant number of people in hospitals and intensive care units. So this virus isn't innocuous, not even to the young people.
Yeah, that's what we're seeing in the UK as well. So when we opened up society, you could see, obviously doing a lot more testing, it was much more common in the young, and now many weeks later, we are seeing 45 to 64, and then even above that age being infected.
Yeah.
They're the people in hospital. Yeah. So a broader question, just two more. Are you assessing the indirect effects of COVID and the mitigation measures? Because obviously if you only had 0.9% of your population that were infected, but you had measures that were put in place to stop the spread that also have consequences. So I know this is not the work of your own team, but maybe colleagues, are they looking at mental health, well-being, and those other outcomes?
You see, there is absolutely clear that one of the reasons that we were successful this spring in containing the first wave is that this nation of usually extremely unruly people followed instructions from the authorities. And actually, when I was driving to work in the morning during this first wave, there was hardly any car on the roads. Now we have put in place the same measures. And when I look out to my window, I can see that the traffic is almost like nothing had happened. Mm. So my guess is that if you can use people's behavior as a measure of how well they feel about measures like this, we are probably becoming very intolerant to them. That is, I anticipate that is going to cause us problems when it comes to attempt to contain this wave. But it is interesting, during the first wave, the society was very cohesive and people were relatively high-spirited. You had the feeling that people felt that they were participating, they were fighting towards a common goal. So I don't think that people were depressed because of the containment measures this spring. I think that people felt they were participating in something that was good for society. And I'm a little bit afraid we have lost that a little bit. And one of the reasons has to do with the constant propaganda from the people who own the tourism industry, emphasizing the importance of handling this virus like we were a nation of Donald Trumps, just behave like the virus doesn't exist. And that has, I think, undermined a little bit the feeling of cohesion. So my guess is that if indeed the containment measure will in a way be forced upon people this time, that is going to turn out to be come at a high price when it comes to the way in which people feel and stuff like that.
Yes, and that is exactly what we are seeing with new measures being introduced, is that the public are far more unwilling to comply or supportive of them, given what they went through in the spring. And then also, as you know, there is more debate, not just from businesses, but also, we should have other strategies. We should have herd immunity. All this stuff is what we're dealing with.
Yeah, I have very good friends in Great Britain who are of the opinion that you should basically push the young people into society, try to get them infected, getting herd immunity. The problem with that is that it is very difficult to isolate young people from rest of society. So I think it's a interesting theoretical possibility, but I think it's not practical.
Yeah, absolutely. I agree. So just a couple of other questions. I do want to ask you about the airport testing. Just you explained it very clearly, but clearly it's not a perfect system. But would you say that given that we can't cut off our countries indefinitely from travel, do you think that this system of the first test followed by 5 days later in general is one you would recommend for other countries? Do you think it's worked well?
it turns out to be extremely effective way of preventing infected people from getting into the country. Having just one screen at the airport will allow you to catch about 75 to 80% of those who are infected, but you're going to let 20 to 25% of them in. In Iceland, this small island, having this system is practical, all right? It is possible to test, separate, have them 5-day quarantine and then test. It's going to be difficult in bigger societies. And at least in Iceland, when you do that, you have to accept the fact that tourism is dead, all right? And some people are grief-stricken by it, but some of us aren't particularly fond of tourists, but that's a different issue.
That was a very diplomatic answer. We've seen in the last few days a near-patient capillary blood lateral flow antibody test that's being developed by a UK consortium, and it's being used at one of our big airports, Heathrow, or is being considered for when we open up again. So it's the so-called antibody passport. I wonder whether you've got any ideas on that.
You see, after having spent substantial energy looking into specificity and sensitivity of antibody tests, I would be surprised if this capillary test would be worth much. Yeah. I'm skeptical of it. I'm very skeptical of it, and I don't know what you're going to do with it if someone is not antibody positive. What are you going to do with that? Are you going to punish people for not having gotten infected?
Exactly. Yeah. Yes. Final question: is the testing and the contact tracing coping well now with the second wave, given that we're so slow down?
The contact tracing is doing reasonably well today. I'm not entirely sure whether it's doing worse or better than it did this spring, because it is difficult to assess that. But this is the task is the task is more difficult, because in the spring this was most people coming from abroad, and it was the idea the task at hand was to find those who had been in contact with those who were coming into the country. This is a little bit more difficult, but we are constantly, we are sequencing the virus from every single case. So we are at least making absolutely sure that this is one outbreak. This is not many individuals coming in. And we are also looking at the accumulation of mutations, and they are helping us to determine who infected whom or what. We are going to succeed. My prediction is that within the next 3 weeks, we are going to bring this down to what it was in the beginning of May. Because basically, if we do not see decrease in viral load or decrease in accumulation of mutations by next Sunday, we will go I'm convinced we will go to an almost complete lockdown.
Right. Okay.
So we have a method to catch the change in the tide before we begin to see fewer individuals diagnosed. Yeah. So we feel fairly confident, although we are concerned, all right?
Well, we're very envious of the sequencing work and the expertise that you have in terms of responding and supporting Iceland's response. So I will stop there with the questions. I think I managed to cover mostly all of them, even though there's a couple of them left. That was excellent. Thank you very much, Dr. Stefansson. I know you have another meeting to go to, so I will email you, but just to pass on my sincere thanks. So I'll close now, but I am going to just introduce our webinar that we're having in November to the audience. So thank you very much again.
Thank you, guys. Thank you very much.
Thank you. So colleagues, we're going to be restarting. I'm sure the screen will sort itself out in a second. It's a bit fuzzy, so we can't see it, but you can get the gist. Anyway, we're having our next webinar on November the 2nd. That's a Monday. I'm sorry that you can't see this. There we are. At 10 a.m. By then it will be GMT that we're on, not British Summer Time. And you will remember that we had Professor Callum Semple a few months ago talking about the Icelandic consortium, this huge consortium of patients hospitalized in many countries with COVID-19. And we've got two leading researchers here at Edinburgh who are contributing to that, Professor Ewan Harrison and Dr. Anne-Marie Doherty. And both of them are going to be presenting the absolute latest findings from the consortium and the cohort on November the 2nd. So please do join us then. Please do encourage your clinical colleagues to join us. And I'm also working hard to secure a Uruguay webinar probably fairly soon after this one, and we have others in the pipeline. So we are committed to continuing this webinar series until the end of the year, and then we'll consider further. So thank you very much to everybody who joined us via Zoom, and also I know additional people are listening on YouTube. Please do draw the attention of your colleagues to the YouTube link and to the PDF of the slides. I think that you'll agree that was fascinating. And I look forward to having many of you join us on November the 2nd. So we'll close the webinar here. Thank you very much.